So in this mini lecture, we're going to focus on bacterial syndromes that range from very common, like strep throat, to immediately life-threatening, like meningitis and meningococemia. The goal is not just memorization, but clinical judgment, and to know what looks routine, what looks serious, and what should trigger immediate referral or emergency action. So that'll kind of be the focus and the plan as we move forward. Streptococci are gram-positive, but unlike staph clusters, they are often described in chains or pairs, and it's somewhat dependent on the organism. So group A, which is a beta hemolytic strep, causes classic strep throat, impetigo, and can lead to aggressive soft tissue disease. Streptococcus pneumonia is different. It can cause pneumonia, but also sinus infections, ear infections, meningitis, and bacteremia. It has a thick capsule that helps it resist phagocytosis. And group B strep is important in pregnancy because colonization in the birth canal can be very dangerous to the newborn during vaginal delivery. This slide reminds us that not all strep is the same and clinical context matters. So several vaccines are commonly used to immunize patients for multiple, but not all, strains of pneumococcus. Many of your athletes may be fairly young, and as a result, this may not be something that we're commonly looking for. But for instance, strep throat, right? This may be something that does tend to happen relatively common. Something like the group A hemolytic strep that we talked about, that has certain pattern when it's stained, and this is why you often go into the doctor and have a strep test with a throat swab. This is why they swab the uvula, so that they can identify the stain that's what bacteria is on the throat. So strep pneumococcus is first-line defense is generally phagocytosis, but unfortunately, as I mentioned, this type of staph has developed a thick capsule, so it's kind of resistant or resilient to that defense. Now, group B strep, we, as a reminder, said, hey, this is relevant with birth, and the child can become infected. Now, in this early age, the critical point here would be, if infected in the early age, this can lead to death. And this is why it's so important to maintain prenatal visits. Now, just as a real quick reminder, your IgG antibodies are the only one that will cross the placenta because it's the smallest. Infants have minimal adaptive immunity, and so the antibodies present would, in this case, be from the parents. Now, following delivery, the infant is going to start producing their own antibodies, and they're going to be, as they're exposed to different pathogens. So we'll keep in mind that this inherited protection kind of deteriorates over the first 6 months of life, and then the infant starts to get their own. Breastfeeding, of course, does yield the IgA to the infant, so it's also important to keep that in mind. So with our core organizing idea here, really understanding that streptococci are gram stain positive, and the clinical syndrome depends on the organism, the context, and the host variability, which is why the staining and the swab is so critically important for identification. So this is a very practical slide because in suspected strep throat, we use what's called a Centaur criteria. And this is useful as a clinical guide. So there are 4 criteria that when we see kind of leads us to believe, okay, this is what's going on. And that is exudative tonsillitis, tender anterior cervical nodes, fever, and the absence of cough. And the absence of cough matters because cough can actually point more toward a viral illness, but the context again still matters. So here in this image, we are reminded that we have a number of conditions that are happening, all maybe simultaneous. And we look and see erysipelas. This is a rapidly progressing cellulitis. And so in this condition, the skin's very hot to the touch, and the redness often is spreading very quickly. So in the picture of the leg that we see, the doctor might put a pen mark at the line of redness. 30 minutes later, come back and determine whether the redness has spread past the mark. So in this case, it's not just red skin that we're worried about, but it's hot, spreading, and rapidly doing so. And so this might indicate more of a serious infection. The mononucleosis image that we see, there's a reminder that not every exudative throat is strep. So you have to keep a broader differential when we're looking at some of these classic presentations. Now, I have said exudative a couple times, so I want to make sure we're on the same page. This is a fluid that's being released from the blood, often described as maybe a pus, and that's what we might see. The Centaur criteria that I mentioned, this might have a very high sensitivity, 90+% of identification that if we see these 4 criteria, a useful guide to what's actually happening in the body. In this picture, erythrogenic toxin, we see a consequence of streptococcal toxin-related disease. Strawberry tongue jumps right out at you. It's not specific to strep, but it should make you think about it. Scarlet fever, this gives that rough sandpapery rash because of the erythrogenic toxin. We see peeling after illness. The peeling in the hands and the feet, and that image shows how the patient may look after a recent strep-related illness. One concern here is that the immune response can keep going and cause downstream damage. This is why prompt treatment can matter. It's a good place for us to remind ourselves that some infections cause harm, but not only because of the organism itself, but also because of how the body is responding to it. So we see the strawberry tongue. In this case, take note of the loss of the papillae, and the tongue looks bare and red. The peeling of the hands and feet, right? They may have had the strep infection a week ago, and in this case, a doctor would want to treat that strep to prevent the patient from making too many antibodies, because in this case, the antibodies could go on to attack other parts of the body. So the treatment for this, well, not much you can do in terms of the skin peeling here. The skin's going to grow back. Now, how long is it going to take? Well, possibly a few days, a week, but we should be able to kind of move forward from that. And then, of course, we see the scarlet fever rash, which I said was an erythrogenic toxin, the rough sandpapery-like look. So all of these help to identify this toxin-related disease, and some of those streptococcal diseases cause the harm through that toxin effect and the immune-mediated downstream consequences. Necrotizing fasciitis. Necrotizing fasciitis is one of those diagnoses where you don't want to miss it. If you see it, definitely refer it out for proper identification and diagnosis. Certain organisms are going to produce enzymes that help the infection spread through tissue, and they're going to destroy the surrounding structures very rapidly. So this often starts looking like cellulitis or redness, but then it progresses and becomes much more aggressive. If the pain, skin changes, systemic illness seem out of proportion, then that should definitely put up some flags, raise some concern. The exact cause could vary, but the teaching point is urgency. So this is not something to just watch casually. Necrotizing fasciitis is where the enzymes may cause the strep to actually eat the flesh around the infection. Now, in the image that we see, the tattoo may actually have been the cause of the disease. How long would it take to get this bad? Well, typically starting as cellulitis and redness, but usually less than a week, and it gets pretty aggressive. So urgency matters. It's not something to watch casually, but rather don't miss the diagnosis, refer it out if we have this particular sign in front of us. Pneumococcal pneumonia is a serious form of community-acquired pneumonia, often with abrupt onset of fever, chills, cough, chest discomfort, increased respirations, and shortness of breath. Now, in the young athlete, a minor cold should not usually make somebody look terribly ill. So if they show up and they're clearly sick, especially with respiratory signs, I think it's fair to say they deserve evaluation. Now, lab work may show elevated neutrophils and band forms, meaning that the body is pushing out immature neutrophils in response to this infection. On a chest x-ray, consolidation may appear as the white infiltrate that we see, and vaccines have reduced the burden of the worst strains, but again, this is still an important disease that we should make sure we catch and recognize upfront. This slide right off the bat is all about red flags. Stiff neck, fever, headache, photophobia or sensitive to light, confusion. These should all immediately get your attention. In very young children, the refusal to eat or drink and vomiting may also be some clues. So this is not a wait and see diagnosis. A suspicious patient needs emergency evaluation. In the photo, we see diagnostic concept of a lumbar puncture. And so this can be a diagnostic tool where we can identify that meningitis is present. And the long-term sequelae here would be that we could have hearing loss or even permanent neurologic impairment. So it is very important to treat this right away. Also remember that meningitis can be bacterial, viral, or fungal depending on the host and the exposure profile. But first job, recognizing that it may be meningitis at all and then getting a proper referral. The combination of the symptoms is, listed here, stiff neck, fever, etc. Not something to mess around with. Right, this could certainly be emergent, and we want to keep these in mind, especially if the patient has mental confusion that's developing as a later onset in the course of this disease. So the spinal tap, where we see the needle inserted into the lumbar region, this is going to collect a sample of cerebrospinal fluid. And again, it's very important to identify this very quick. The action threshold should be immediate raise of concern and immediate referral out. Neisseria meningitis. Now, this is commonly worrisome in teens and, let's say, young adults. The combination of headache, fever, stiff neck, unexplained skin bleeding, bruise-like lesions that are, present, this is a major emergency. Those black and blue appearing lesions represent hemorrhagic skin, and that can develop pretty rapidly. So if you see a patient who was sick yesterday and now has a fever plus these lesions, do not delay. Activate EMS, get them to the emergency department because this disease can kill within 24 to 48 hours. This is the kind of timeline that we need to be aware of so that when we see something, it's not a go home, wait and see, but it's rather let's get you into the ER as soon as possible. So closing takeaway, the main takeaway from this segment is that bacterial infections exist on a spectrum. Some are common and manageable, others move very fast. Exudative throat, rapid spreading of redness, respiratory distress, stiff neck, unexplained skin bleeding, these all deserve a higher level of concern. So as you're treating or seeing your patients or your athletes, if we're identifying any of these markers, make sure we're getting them the proper care that they need.